ईश्वरं गजाननयुतं गणेश्वरम् अजेन्द्रपूजितं विघ्नेश्वरं अजेन्द्रपूजितं विघ्नेश्वरं अजेन्द्रपूजितं विघ्नेश्वरं अजेन्द्रपूजितं विघ्नेश्वरं गणाधिसन्नुतपदपद्मकरं गणाधिसन्नुतपदपद्मकरं कुञ्जरभञ्जनचतुरकरकरं गुरुगुहाग्रजं प्रणवाकारं गजाननयुतं गणेश्वरम् भजामि सततं सुरेश्वरं गजाननयुतं गणेश्वरम् Thank you.
Thank you, Viveka. I now request Archana Ravindra, founder president of Indian Osteogenesis Imperfecta Foundation, to deliver the welcome and introductory note.
Thank you. Good evening and a warm welcome to all of you. We are honored to have Dr. Vrisha Madhuri, Professor of Orthopedics in the Department of Pediatric Orthopedics at CMC Vellore. CMC Vellore holds a special place in my heart, for I went through major bone straightening surgery here as a child. I see many people logged in, and I'm so thrilled.
ಇಲ್ಲ reference letter ಇದೆ ನೋಡಿ ಅವರ ಹತ್ರ ನಾವು BB positive ಇದ್ದಾರೆ.
I see many people logged in, and I'm so thrilled that each of you have made this event important enough to be there virtually. We hope all of you are keeping safe and staying well and continuing to practice social distancing and masking. Today, we are gathering virtually to celebrate Wishbone Day. Wishbone Day is one of the most important days in the OI calendar. It is celebrated on May 6th to raise awareness internationally for osteogenesis imperfecta, or OI, as it is commonly known. OI, as many of you are aware, is a brittle bone disease. The idea of celebrating Wishbone Day was conceived by Joe Regan of Australia in 2010 with the intention of raising awareness of the OI community in the world. This idea was quickly embraced and is now used for positive propaganda by the OI community. Over the years, Wishbone Day has built momentum and is celebrating the lives of many people with OI, their achievements, and showcasing their gratifying lives. OI is a rare, permanent, genetic disorder that prevents the building of strong bones. Children and adults with this disorder have bones that break easily, and they may have deformed bones. OI can also result in fragile teeth, spine curvatures, hearing loss, and weak muscles. The Indian Osteogenesis Imperfecta Foundation, IOIF, is a registered charitable trust with the mission of supporting people with OI. Our nonprofit organization was established in May 2018. IOIF has been celebrating this momentous day by bringing awareness, educating the community, and sharing triumphs of many OI warriors. I would like to express my sincere appreciation to all of you who have helped us make this event come together. Once again, I welcome Dr. Vrisha Madhuri, all the members of the OI community, and the participants from the medical fraternity. Thank you, and I hope you will all find this session to be a significant one.
Thank you,
Over to you.
Archana. Thank you. Ioif has always been receiving many queries over the past few years from parents, OI warriors, about the various treatment options that are available for them and their children, especially about stem cell therapy. And there's always many questions what to do, what not to do. So IOIF thought who better than Dr. Vrisha Madhuri to enlighten us today. Dr. Vrisha Madhuri is a professor of pediatric orthopedics at CMC Vellore. She received her MS in orthopedics from CMC and went on to receive her MCH in orthopedics from Liverpool University in the United Kingdom. She has received many accolades, including an award from the National Research and Development Council, Government of India, for societal innovation. Dr. Vrisha Madhuri is widely published, has several patents and numerous research projects which have transformed pediatric orthopedic practice and help to deliver quality care for children. Dr. Madhuri is also the project coordinator of the stem cell therapy for children with osteogenesis imperfecta project under the Indo-Swedish tie-up at the Christian Medical College, Vellore. It is our pleasure to have you, ma'am, today with us to enlighten us on the evolving treatment aspect of osteogenesis imperfecta and stem cell therapy. Welcome, and I'd like you to carry on further.
Good evening. It's a great pleasure for me to be addressing OI community under Archana's and Dr. Abhishek's stewardship, the Indian Osteogenesis Imperfecta Foundation. I previously saw Padma Priya, whom I have treated 40 years ago when I was just a registrar, junior registrar, and she
Yes,
was.
ma'am. Hi, ma'am.
Hi. And she was.
I'm very, very happy, ma'am. Very happy to see you.
Very
You are
happy.
my dearest soul.
So,
Oh my God.
I think
Thank you, ma'am.
I have seen her again 2 years ago, and I hope you're doing well, Padma. What I would like to talk about, I think there are a lot of misconceptions about osteogenesis imperfecta, and I find sometimes children who could be treated very well and do extremely well if they were started on treatment from very early age. The parents are going around from place to place looking for a miracle cure when a proper treatment is very close at hand. So that is why I thought before I go on to a miracle cure like stem cell therapy, which we don't really yet know 100% whether it works or not, we should first talk about the regular treatment which is available for all the patients. So that is why when Archana asked me to talk about the stem cell therapy, I said, please allow me to touch a little bit on the treatment of OI in general, so that people understand that that can also be of benefit. So thank you, Archana, and thank you, Abhishek. And I will now start on my presentation. I don't know why this is not moving. Okay. So osteogenesis imperfecta, I know you all of you are aware, it is susceptibility to fractures with trivial trauma. And because these fractures happen so often, many of our patients develop bone deformities. And one thing which people don't realize unless they're suffering from it is there is a lot of growth deficit. So most of the severe OI will be only like on the 5th percentile of the growth curve, and even lower than that sometimes. So these are the major features. So they not only have fractures and deformities, they also have growth deformities, and not just in the long bones, but also in the spine they can have the deformities. So when we look at the radiological features basically just a very briefly that I want to talk about. Even when the child is born, you can pick this up. There can be fractures in the severe types or within the first few months after birth. If you look at the skull, you see you usually have about 6 or 7 major bones in the skull, but here you see like hundreds of little islands of bone, So these are called Wormian bones. So the children have that. If you look at an in utero picture in the second trimester or later, you may see fractures of the long bones. Much more than that, you'll see severe shortening of the femur and the humerus in the upper limb. So the children sometimes in the severe types are born with multiple fractures. And if it is very, very severe type of OI, like a type 2 OI, they may not actually survive to take birth. So these are the major issues with the OI. The prenatal diagnosis is possible and can be done within early second trimester anomaly ultrasound. And with that itself, you can see that they have femoral shortening of more than 5 standard deviations. So that is quite classical. And then secondly, you can see that they have a short, other than the shortening of the bones, if you touch with the probe the skull, it is very thin and it is easily compressible even with the ultrasound probe. The children have blue sclera in some types of OI, and you can see the teeth of this baby. The primary teeth, that is the milk teeth as we call them, can be opalescent. They lack the white color, but when the new teeth come, they are a little stronger than this, and they have the proper dentine and they are more white in color. But however, these teeth also are very classical of OI, and they are called dentinogenesis imperfecta. So in addition to that, the severe chest deformities as well as the thoracic deformities that happen because of the spinal deformity can cause, affect the ability of the child to breathe and can also cause severe cardiac compromise. So all of these are things which make the life difficult and make the quality of life not so good for the children and adults when they become. So one of the things that I talked about, which people don't realize, is the growth. So if you look at the type 1 OI, which is the mildest form of OI, and you look at the top white color little dumbbells that are there, you can see that they are almost just a little shorter than the normal. Okay, so if you consider 0 as the median, they are little, their heights are little shorter than the normal. But when you look at the type 4 OI, which is the middle ones, the gray ones, the darker gray ones, they are definitely much more shorter than that. And when you reach the type 3 OI or severe OI, they are actually lying somewhere close to the 5th percentile. So based on the type of OI, you find that, and as the time goes on, so at 5 years, your height is a little better, but at 10 years, your height actually falls more. 10 to 15 years, your height falls more below the normal growth curve. So as the time goes on, you don't follow up the growth chart, but you start falling off the growth chart. So your percentile height starts getting worse. In addition to that, some typical type of OIs like type 10, they can have joint deformities. And in yet another kind of OI called type OI, when you get fracture, you get huge big swellings. They look like tumors and people can mistake them for osteosarcomas. And this is another kind of OI that can happen, but the diagnosis can be made if you understand that they do have problems with their moving their forearms and the elbow, because the forearms cannot supinate and so they cannot rotate their forearms because there's a fusion across their forearm bones. So that is actually almost pathognomic of a type 5 OI. So there are 24 known OI genes which can cause. Most of the OI is caused by COL1A1 and COL1A2 genes. And they form in other countries in the world, they form almost like 80 to 85% of all the OI patients. But in our country, they form only about less than 60% of our patients. So the so-called dominant OI or COL1A1, A2 OI and the type 5 OI actually form a much smaller percentage in our country. And the recessive form of OI, that is the one which requires 2 different genes to come together to cause OI, is much more frequent. Okay. So those kind of OIs are also more common in South India, in families where the consanguineous marriages are common. So type 1 OI can be one-off, but the recessive OI is usually can be more in consanguineous families, and we do see that many members of the family affected. So when we look at the mutation landscape in our country, with just talking about 65 of the samples, we've done now more than 160 samples, but looking at the 65 samples that you have, you can see that almost every type of OI was presented, but only 15 of the glycine substitution abnormality, which is the commonest abnormality in the West. This is the one that is commonest. Okay. And this is just to show you how we can correlate from the time you get the first fracture. And with that, we have correlated what kind of OI you're likely to have. So some recessive forms of OI, like Serpin F1 or wind type of OI, they tend to present later. So their first fracture will be more after 2 years of age. But the more severe types of OI, uh, like the type 3 OI, they tend to have a fracture much earlier. So they will be fracturing within 6 months of age. So we have actually seen and computed which OI is present at which age. We've also looked at the different types of deformities and correlated with that with the OI. So some kind of deformities are more common, like a OI with hardly any deformity is more likely to be in col1, A1, A2. So similarly, we have plotted to see which deformity is seen in which type of OI. So previously we had OI numbers going up to type 16, 17, 18, but now almost all the OIs have been compressed back into type 5 types of OI, because when you are looking at them phenotypically, when looking at the child and trying to decide, there are actually only 5 types. So the type 1 is the mild non-deforming type. These children have blue sclera. Type 2 is the very severe form where the children may die perinatally just before or after birth. Then type 3 is the one which is moderately severe to very severe deformity. And this can include 3, 4, 3, 6, 7, 3, 6, 8, 9, and 10, and Buck syndrome. And the last one is the type 4 OI, which includes, other than the 4, it includes also the type 7, type 9, type 12, and type 13. So basically, now the new type 1 to 5 OI, you can decide based on the phenotype. So how do we manage the OI? And I have concentrated more on the severe form of the OI rather than the mild form of the OI. Mild form of the OI may not need any treatment, or if it needs treatment, it will be if they have getting vertebral compression fractures. Then in that case, they need famidronate. Otherwise, if there's just one bone which tends to fracture repeatedly, just surgery for that 1 or 2 bones that are causing problem will be enough. They may not need continuous bisphosphonates. So for that, we have to follow them up for their vertebral fractures. The other children require both orthopedic surgery, and the medical treatment, in addition to physiotherapy, occupational therapy, and they may require braces. So when I visited Sweden and I saw how the OI is all managed mainly in one center, and I found that hardly any child requires wheelchair, and I was quite horrified that so many of my patients were on wheelchair. And most of it is not because our patients were worse off, but it was because they were not getting adequate supportive treatment. So it's not just doing the orthopedic surgery and sending them off that matters, but also to provide them supportive treatment as minimum immobilization, to give physiotherapy, occupational therapy, give them braces so that they can stand, and most importantly, decrease the amount of immobilization as much as possible. Because every time a child is immobilized, they lose bone mass in addition to what they're losing because of their disease condition. Orthopedic surgery can definitely splint the bones and help them stand. Bisphosphonates are a must now for managing OI because it actually changes the quality of life, it improves their height, and it decreases the pain quite a lot. Okay, so this is very, very important. In addition to that, even when the patients become adults or adolescent, they can shift over from the injectable bisphosphonate to other bisphosphonates type. One of the things which we don't realize is often is that the OI children and the adults suffer from quite a lot of pain, and it is important to understand that they have pain and to take care of that pain. So analgesics should be given. Newer treatment like gene therapy and the stem cell therapies are now coming into picture, and I hope that they will be able to solve a lot of problems for the patients. Now, I think very early on, it is important that, to understand that OI is one disease, but there are other things which are negatively impacting on the disease and making it worse. So this is something to be kept in mind. Weight-bearing physical activity should be encouraged. So if the child can't stand on their own, then give them splint and give them a walker or something to hold on to and try to make them stand. Because the more they weight bear, the better the bone quality is. That is irrespective of any other factor. Okay. Then as far as possible, avoid immobilization. So about 4 weeks of 3 or 4 weeks of the immobilization is enough in a plastic cast. Don't immobilize more than that, because while they are immobilized, they're losing muscle and bone mass. Then optimize nutrition. Remember, a lot of our OI children are having vitamin D deficiency and calcium deficiency. So if we start famidronate treatment before calcium deficiency and vitamin D deficiency is treated, they become actually a mixture of osteoporosis and osteomalacia. So they actually become much worse. It's like having a renal disease in addition to everything else. It becomes so bad. So patients should have a normal calcium, should have normal vitamin D. If they can't go out in the sunlight, then they should be supplemented for this, and good protein diet. So this is all very, very important. Okay. And normal weight, and we should try and see that they don't get overweight, and they should maintain normal weight for their height. So this is just a general idea of what can be done and what should be taken care of by parents, and who should insist that this is managed properly. Then coming to the surgical treatment, I'm just going to touch on it because not everybody requires it. And the main reason why we would need surgery, so you don't have to start surgery straight away as soon as the child is born or 1 year old. You have to watch and see what is required to restore and preserve the anatomical axis of long bone as soon as the child reaches the age when they can be standing. So to do this is important to put the rod right in the middle of the bone if that particular bone is tending to fracture often or is deformed. Otherwise, the child cannot maintain the anatomical axis of that bone. Okay. So putting this rod in a deformed bone will also reduce the incidence of fracture, and it also corrects the limb-length discrepancy, because if you have deformity in one bone and the other bone is straight, then the child cannot walk because the one leg is in a different position from the other. So that makes it impossible. So always we should choose nails. We should not choose plates. So always nails should be chosen. Both rush rods and elastic nails and telescopic rods can be used. And the important thing is, once we have put these nails, there's no need to actually immobilize them for too long. A few weeks is enough. 2 or 3 weeks may be enough. In Sweden, they don't even put plaster cast. They actually put heavy, thick, padded bandages so that they prevent too much of movement, and they don't try to put plaster cast at all for these children once they have been roded. Because when you immobilize after surgery, you can lose up to 30% of your bone mass, which is quite a lot. That is a huge amount of bone mass to lose just because you have surgery. And plates should never be used, because when you use the plate, actually the bone will break just above it or just below it. So it's not a good treatment for osteogenesis imperfecta at all. So the brush rods and the other rods that we tend to use, they become short as the child grows. So the problem is that every 2 or 3 years, we have to change this rod. So what can be done to prevent this having to change this is, you can use something called as a telescoping rod, which you don't need to change for up to 5 years, because it grows, it opens out. It's one rod inside the other, and as the child grows, it opens out and allows the bone to grow, and it grows along with the bone. So that is important, but it's a little expensive thing. So if you don't have the rush rod, what you can do is you can use 2 rods, one coming from below and one coming from above. So as the child grows, the rods will actually, the overlapping rods will continue to shorten, and that will prevent you having to do the surgery too often. So that is something which has been found also very useful. So these are some of the surgical tips. The upper limb I have not talked about, because the upper limb surgery is done mainly for function. So if you develop a severe deformity in the upper limb or forearm or the humerus, which is interfering with function, or if they're weight bearing with crutches and that causes a problem, then the upper limb bones also need to be straightened. All right. So I will now go on to the medical treatment. So medical treatment is mainly based on bisphosphonates. The commonest and the most popular bisphosphonates are pamidronate. In Europe, they also use neridronate. In some places, in India, in fact, many places in India use zolendronate, because pamidronate is not usually available in all places, because it is mainly used by the units which are treating malignancy. So they're not available everywhere. Older patients can also use alendronate, and there are Indian clinical trials also using alendronate by children, but it's difficult to use. Bisindronate is a good drug, and I would suggest also to look at abandonate on children who are more than 10 years old, because abandonate studies are coming out. It's a very cheap drug. It needs to be given only once a month, and it is available everywhere. So the effect of this pamidronate treatment has to be given in the infant. You have to less than 1 year. You may have to give every 1 or 2 months, but after that you have to give it once in 3 months. And once you've given it so that your BMD has come into within somewhat normal limit, then you can reduce to once in 6 months, and finally to once in a year. All right. So coming to the effect of this pamidronate, it reduces the bone pain, it increases the walking ability, it increases the growth rate, and it also increases the bone mineral density, which is how we actually measure the effect of treatment in osteogenesis imperfecta. and children have less number of fractures and they have increase in vertebral height. That means less compression fractures in the backbone. So the way we assess it, and I think I want you to understand how you know whether your treatment is working or not. Your doctor will do a DEXA scan, which is a very low radiation scan, every 6 to 12 months. And by looking at the improvement your DEXA scan, they can decide whether your BMD has come, is following your Z-score, the median of your Z-score. So if it becomes less than -2, that means you're starting to improve. Okay. And the whole body measurements are also possible if a child is over 3 years of age. So the reason why I was suggesting not to use zoledronate in children is because it has a 20 years life inside the body once it's taken up by the bone. It has been known to cross placental barrier, and it has been known to cause atypical fractures later on. And zoledronate is actually not considered to be such a good treatment worldwide as compared to the other shorter acting bisphosphonates. So other experimental treatments that are available are denosumab and anti-sclerostin antibody. Both have not got a proven efficacy. Denosumab has been shown, at least 2 reports are there which say denosumab is good for one particular kind of OI, which is the Serpin F1 caused OI, where the problem is with the osteoclast activity because a particular factor which should be in the blood called PEDF, which should control the osteoclast, is lacking. So denosumab is supposed to be good with that particular kind of OI. 2 small reports on this particular kind of therapy. Anti-sclerostin monoclonal antibody, not such good reports about it, though it's been suggested. So something that has been talked about, especially for the autosomal dominant kind of OI like COL1A1 or COL1A2, is the gene targeting. So what they can do is, if there's a gene which is behaving abnormally, they can silence that particular gene. So there are 2 ways you can make the gene therapy. You can repair the gene and re-inject the cells, or you can, that is called gene editing, or you can actually put in something in the body, which is just like a drug, like small molecules, which will silence the gene which is causing making abnormal collagen. So if you silence the abnormal gene, then though you will have less collagen, you will have more new collagen. So your severe OI will become mild OI. So that is something called ASO, and that has been talked about in the literature. So what I'm going to emphasize on is the fetal mesenchymal stem cell therapy for osteogenesis imperfecta, and this is an emerging treatment which has had proof of concept studies done, and now it is moving towards clinical trial both in Europe and in India. So the reason why this particular treatment came is because the bone marrow stem cell therapy, which was initially used, it was found that it has only a very short effect. It has a transient effect which lasts for about 6 months. After that, you have to repeat the treatment. And most of the time, if you use adult bone marrow MSC, people have to consider using the matched transplant. So it's like almost like doing a matched transplant, like you do a bone marrow stem transplant. You have to match the cells so that most of the HLA matching is there before you can transplant. Otherwise, it may not engraft. Okay. So this prenatal cells, these are derived from the liver-derived MSCs from the expelled fetuses, which do not survive in the first trimester. And they have been found to be very useful, have been found to give better linear growth, better mobility, and decrease the fracture incidence. So our idea was to do the transplantation of such stem cells to treat very severe form of OI. Okay. So why should we choose this particular these cells is because these are the precursor cells. These are precursor cells. They are found in very, very primitive form at that stage. So they have, just like a child, because the child whom we are going to transplant is a small baby. So they are going to grow on for the next 50, 60 years. So we want to give them cells which are also capable of going on for the next 50, 60 years. So as you know, all our cells, by each cell has a limited life in terms of number of times it can divide. So these cells have much more number of divisions in them than most of the adult cells. That's one thing. Then these cells are known to be extremely bone forming. They secrete a lot more factors which aid repair of the bone. And they are also not requiring immune matching. So they can actually evade the immune cells of the body into which they're going, into the child which they're going, and they don't die. They are not killed because they don't actually tend to activate the immune system of the recipient. So there is preclinical and clinical studies for this evidence. So you can see what the stem cells is. That is the adult stem cell. This stem cell, with under appropriate condition, can become osteoblast, forming bone, can become chondrocyte, can form cartilage, it can become myoblast, form muscle, it can form the stroma of all the organs in our body, can form fat cells, it can form tendons. So it's capable of forming everything. So using these cells, of course, makes sense. Now, as you can see, can you see that little red plate on the right? And in this red plate is actually, it is showing that these cells are capable of forming a much higher amount of bone than the ordinary cells. And if you look at the amount of bone differentiation of the fetal MSCs as compared to the adult MSCs, you can see the amount of bone this can form as compared to this. And again, if you look at the colony forming units, that means they can form that many more colony to form cells. They are much more than the cells which are brought later, which are harvested later, even in the second and third trimester. So here again to show how good bone they form, this shows how good bone, this is the kind of bone that is formed by the fetal MSCs. This is very, very dense bone, okay. These are the various factors which are secreted while the bone is forming. These are the various genes which are being expressed, again very high. And when you look at it again here, this is calcium deposits, again very high. Alkaline phosphatase, which is something which is secreted when the bone is being formed, again very high with these cells. So what they very first trial that was done, and I've been following it up from the time this, I think first in the 2003 or 2004, they did this, first published in around 2007. And they found that this one child, they gave this fetal stem cells to, and they gave it before the child is born. So through the umbilical vein, while the baby was still inside the mother's womb, the cells were given. And otherwise, this child would have had so many fractures because it was already diagnosed with fractures. So it decreased the fracture rate. It increased the bone strength in this baby. It allowed the baby to grow at its own, along its own growth chart before it fell off when the baby was about 6 or 7 year old. And then again, one second one was given, and then again this baby maintained its growth chart. So the no fractures with having received these cells when she was actually having several fractures intrautero. Now another study, 5 children out of 6 did very well in this, but then the effect was transient by Professor Horowitz. They used the adult cells, they did not use the fetal cells, and their effect lasted for little more than 6 months. So we have the proof of principle, and based on this, and of course subsequently a few other cases that were done, it was found that we can go ahead. So it was safe because 2 other babies have had the same treatment, and it was used for very, very severe forms of OI. And they found that they found an identical child with the identical gene in another country, who they found the baby survived for 5 months, while this child going on for several years. I think she's now about 12 or 13 or 14. She's actually doing very well. Good height, no fractures, and doing well in life. I think she has had 1 single fractures while playing at one time. So looking at this now, you can just see, it's just to show you she's following her growth curve, both in height and weight. So now I will come to our study. So our study is called Boost to Little Bones. And the study that was being done previously is simultaneously, started in Europe, is called Boost Before. And our study is a phase 1-2 clinical trial. That is, we want to see that it is safe and we want to know it is effective. And we are going to give fetal liver-derived stem cell for treatment of severe osteogenesis imperfecta. It is funded by International Division of Department of Biotechnology and Vinnova in Sweden. A co-PI along with me is Dr. Cecilia from Karolinska Institute in Sweden. We have all the permissions from the IRB, from the stem cell control group in the ministry, and from the Drug Controller General of India, and this trial registered both nationally and internationally. And the 2 sites are Christian Medical College Vellore and Karolinska Institute, Sweden. We are the reconstitution and clinical site, and they are the manufacturing site. And this is the children who have been recruited. Just to give an example, 1 child is recruited. So while we are recruiting children for treatment, we also recruit children as control because many patients don't want the treatment. So we start them on family unit therapy and we are following them side by side. So these are the kind of children. See, you can see in the skull X-ray, so many small bones, which means these are Burmese bones, fractures. At birth itself, the children are having multiple fractures. So this is what we do. So in addition to giving the IV injection, which is what is recommended everywhere, and not what is not done is an injection into the bone. So since we were giving our treatment to older children, because most of our children are not able to access treatment before 1 year of age, we decided to give our children treatment directly into the bones, because once they start breathing, the children can filter out stem cells in their lungs. So if we give it directly into the bones, actually it is going directly where it is needed. So that is the rationale for giving directly injection to the bone. So we give these stem cells directly into the bones, you can see, and all the weight bearing bones. In addition to that, we also give it to the vein. Okay, so this actually, when we first did it last year, it generated a little bit of interest, patient story, and as well as the Department of Biotechnology was very proud of this new therapy. So it was advertised for them also. And this is the team. So you can see it's not an easy job. A huge number of people are involved in the treatment for this therapy, because you need a radiologist, you need to make sure that the thing goes inside well. The reconstitution, it requires 3-4 people, a lot of people monitoring it, in addition to the anesthetist, the nurses who go with the patient and follows it up. So it is actually very carefully monitored clinical trial. Our first transplant at CMC Vellore, this is actually the result after the first 3 months after the transplant. You can see the change in growth. So he was actually below the 5th percentile, well below the 5th percentile. At 3 months, he touched in his height, 5th percentile. He grew 5 centimeters within 3 months. And the next 3 months, he grew another 5 centimeters. So he actually crossed the 5th percentile and became 10th percentile. That is like a normal child. And same thing in the weight, his weight increased to 50% of that, means right in the middle of the 5th percentile. So definitely growth change was seen. So this boost before is the European trial that you can see, and the boost to be is the Indian trial. Okay? Because and it is an open label trial, it's multiple doses. We are giving 4 doses to each child, and our trial is actually only in 1 center. Their trial is in 4 or 5 centers in the Europe. It is going on parallel. So while they are recruiting patients, we are also recruiting patients. In fact, I'm getting hassled quite a bit by people from outside the country, Germany and all that, who want to get enrolled in our trial. So that is also happening, but we are not allowed to actually recruit outside India. So safety and efficacy, so far everything has been safe. We haven't had problem. We have both historical and untreated controls whom we are treating for free, and we follow them up just to find out how our child who underwent stem cell transplant will be doing. We are recruiting another 5-6 patients before the end of this year. They're all ready. We're waiting for the cells to arrive. So the treatment product that we're using is mismatched stem cells from the fetal liver derived, from the fetal cells, liver derived. So I think now, going away from the hype of MSCs, I would again like you to remember that main thing in the OI treatment is bisphosphonates, internal splinting by surgery, and please follow the clinical trials carefully. And if you think that you will benefit from it, please don't hesitate to contact me. Thank you.
Thank you, ma'am. We have few questions for you put out by some of the parents.
Sure.
Is Sunita Ravi Kumar there? She had a question for you. Sunita? Yeah, Sunita, you can ask.
Able to hear me?
Yeah,
Yes,
I can
yes.
hear.
Hello. Yeah, hi, ma'am.
Hello.
Hello. Hello.
Yes,
I
we can hear you.
Go ahead.
Okay. Hi. My daughter is 1.5 years old.
Okay.
So she's of type 1, mild type 1.
Okay.
As we parents both don't have any kind of symptoms or anything. Like,
Okay.
hello.
Yeah.
Go ahead.
Yeah,
Okay.
like both the parents we have got negative. So the genetic testing and all. So just want to know how can we treat her with the stem cell therapy?
So if it is a type 1 OI, I'm assuming she has not had any fracture, because at 1.5 years for you to diagnose a type 1 OI, it might have been. Did you diagnose because of the blue
She had
sclera?
no. Yeah, blue sclera. Yeah, that's it. And she had.
Hello?
Ma'am, thing is,
So
she's
I
mild
can
type.
see her. I can see her question in the chat, so I can answer that. So
Yeah.
during mother's pregnancy, yes, it is possible to diagnose. Besides doing the ultrasound, anomaly ultrasound in the early pregnancy, when they can look at the length of the bones, they can also do a genetic amniocentesis and a testing. There are, so that is something that can be done. There are techniques to even do it through the fragments which are floating in the blood, but I think that will be much more difficult. I think amniocentesis will be the another way to do it. If it is type 1 OI, the treatment you do not have to be so worried about. What I would suggest is follow her fractures as well as follow her spine. Okay, if the backbone is not developing any fractures and staying straight, then you may not even need to take the bisphosphonates, but you should keep following her DEXA scan as well as get a regular follow-up done of her spine. If she has fractures and she's tending to fracture only in one bone, then we need to rod that bone. If she's not having any fracture, she does not require any rodding, if it is truly type 1 OI. So for that, other than phenotyping, you can also get a genetic testing done and confirm that it is one of the milder forms.
We have a question from Dr. Chandan, who says, how can we harvest the fetal MSC?
So actually we don't, so what happens is usually it is taken from fetuses who have been expelled, who are within the first trimester, who have normal healthy mothers, who are giving consent for the cells to be used. So only the liver is removed from the fetus. These babies are hardly, you cannot even make out, they are so tiny at that stage. So just the liver is removed and the cells are isolated from the liver. And then they are grown in the lab under facility, under the GMP facility.
We have a question from Nirupalini, who has a 2-year-old son. He's the only OI member in the family not inherited from parents. Her question is, if we have not preserved the stem cells, how this therapy can be given to him?
So this baby is type 5 OI.
It is type 5. Yes, that's right.
So if it is type 5 OI, the good news is that other than the deformity and all they have, this is not a very severe form of OI. It's a relatively milder form of OI. So initially you have done, if you have already done 4 infusions, follow the DEXA. How old is the baby? 2-year-old. 2-year-old is difficult to actually interpret the DEXA before 4 years of age, because every year the DEXA keeps changing by about 30%. So best thing is to just do a total body DEXA, even that is useful only after 3 years of age. But I think if you can just follow it clinically, if he's not having any fractures, you can give maybe one more round of pamidronate and then just follow it. By that time, he'll be old enough to follow on the DEXA. I have found that I've not needed to give continuously pamidronate for most of my type 5 OI. Most of them don't receive it regularly. So if they've had it and their DEXA comes up, then we just discontinue. And they are not the very severe type of in terms of fracture rate.
Yes. Naman has a question. Stem cell therapy is same for all type of OI. My son is type 15. Is it severe? Can I? Okay.
So I think basically I feel that at the moment in this particular clinical trial, we have chosen only one particular type of OI, which is a severe glycine substitution abnormality. It's a glycine substitution abnormality, we choose it. So we would actually, and we are taking children only 1 to 5 years so that we can actually compare with the controls. It's difficult if we have too many different groups, then we will not be able to interpret it. But I think for a child who is severe OI and 15 years of age, I don't think at the moment we will offer it, but if he does need it, maybe when it becomes open as a therapy, as a general therapy, then it will be possible, but not right now. But we need to know what type of OI he has. I think there is theoretically no reason to say that they will not improve, but practically speaking, in a clinical trial mode, we have to restrict who we can do so that we can actually interpret the results. Because if we take too many different types, we cannot find an exact identical control for them.
Soumya, you can ask your question.
Thank you, Dr. Abhishek.
Yeah, go ahead, please.
Yes,
Am I audible?
Yeah, we
Yes,
can
yes.
hear you.
Yeah. My daughter is 10 years old now, and she has undergone 7 to 8 surgeries. So right now, doctor had told me that she has coxavara. So we are giving her pamidronate from nearly, she was almost 1.5 years old. From that time, we are giving pamidronate. But recently, from 3 to 4 years, we have switched to zoledronate. Now, my question is, when we had done genetic testing, we had got 2 genes. One is serpin F and one is spark gene. So it is like she has type 6 as well as type 17, I think. So
Okay.
is that possible to, like, one kid has 2 genes? So is it
Yeah,
possible?
it is very common in our country. We have many children with 2 genes, and not only they have 2 genes of OI. We have many children with 2 genes of OI. We have many children with 1 gene of OI and 1 gene of another disorder. So it's possible. So I think SPARC is a very rare type. Okay, it's a very, very rare type, and it's not such a nice type to have. Also, it's a little rare type. The serpin F1 is something which is not very symptomatic when they're born and not very symptomatic till they reach about 2-3 years of age, and then it starts to get worse. So finally it becomes like a type 3 OI, which is a severe OI. So it is classified under type 3, but at the same time it is a OI which gets worse as the child becomes more and more old. So it is better to start treatment early. And though there is one very strongly recommended that we should give denosumab for serpin F1 type of OI. I still feel that in our children, we have about 17 children with serpin F1, and they are responding well. And there were children who were not walking before, who now after treatment with pamidronate and surgery for correcting the deformity have started walking. So I think that is something to start with while exploring the option of denosumab. But if he has a lot of deformity, I would definitely suggest that all bones should be anatomically aligned. So it's not a question of how many surgery, but whether your bones are straight enough for you to be able to stand. I would also suggest, because it's like a more like osteoclast overactivity. So the more you are immobile, the more the osteoclast will become active. So you have to take on so many things which don't worsen the osteoclastic activity. You should maintain vitamin D level. You should make sure that the child is standing or walking. You should make sure that the child
Doctor,
is.
I wanted to ask something about her mobility also. Before Coxavara, we were able to make her stand by braces, and she used to take few steps in the reverse walk. But after the Coxavara has started, she says she can't stand because the pelvic bone, it has bent. So I want to know more about Coxavara, because when I googled it, it says that it is a very complicated surgery, and she has rods in her other bones, femur, tibia, in her upper arm. So I wanted to ask, how is this surgery different from the other one, and what are the things we have to look before going into Coxavara surgeries?
I think I have removed the slides for the Coxavara from this presentation because I thought it was parents and not for doctors. But basically, you can get Coxavara in 2 different ways. The bend can be in the somewhere in the proximal femur, or it can be little higher. So it is treated by a special kind of surgery which allows you to restore the neck shaft angle. It is a difficult surgery, but there is a surgery which is described for this.
Okay.
Thank you.
And
We'll just have one last question from Naman Sharma.
Yes. Good evening, ma'am. Ma'am, my son is osteogenesis type 15. And my question is, does it affect the central nervous system? First is this. And secondly, like he underwent 2 femur surgeries, he has 2 bones. What is the appropriate age for putting the transition rod?
I think we need to actually have a little bit better direct consultation for something like this. What you're asking is extremely, extremely specific. So we'll have to see the child and we'll have to see what is going on. OI per se, very rarely only affect, I think there's only very rarely it affects the CNS, but there is like wind abnormalities and all which are known to affect CNS. So it's not that it doesn't happen, it's rare, but we would need to see the patient to advise you.
Okay, ma'am.
I think I can see from Gautam. Gautam, there. Hi, Gautam. How are you? The dose for the stem cell is that we use is 3.2 millions cells per kilogram of body weight for the IV dose, and about same dose for the intraosseous dose.
Okay, thank you very much.
All the bones combined.
Thank you. Lovely talk.
Yeah, thank you.
Thank you, ma'am. Thank you.
Thank you.
We thank Dr. Vrisha Madhuri for this wonderful session on the various aspects of treatment in OI and stem cell. Thank you, ma'am. We'll now move on to our next talk. I now request Paranjyoti ma'am to introduce our next speaker.
Welcome, Saswat Kumar Swain. I am very happy to introduce just little introduction about him. Saswat Kumar Swain hails from Bhubaneswar in Orissa. He is currently works as a software architect in Avonade and resides in Gothenburg, Sweden. He has done bachelor's in engineering in electronics and telecommunication, and also he has few hobbies. And his hobbies are photography, reading, listening to audiobooks, and also astrology. Very unique. Nowadays, his interest also has come to learning piano. That is wonderful. And happy to tell his condition has not become a barrier for him to better himself every day, to improve himself. We have to salute him for his fighting spirit and hope he continues to inspire the whole mankind of aspirants like himself. We at Ioif are very happy that he has accepted our invite to speak to us today. And of course, he is going to speak about life with OI in India as well as abroad. Welcome, Saswat. Will you please come on?
Thank you. Can you see me?
Yes, thank you.
Okay. Hi. Thanks for inviting me. It was a very good information session. I really didn't know so much about OI.
Not audible.
Sorry.
You are audible.
Am I?
Yes, yes.
Okay. So thank you. I didn't know so much about. I just knew mine was type 2. That's all. Though I knew so many things. So good. Thanks for the introduction. I don't really have a fixed agenda what I'm going to talk about, but basically what I try to say is I try to tell my experience in 4 stages of my life. I think a couple of days back.
You can speak about yourself and the life with OI in India and abroad. That's the thing you have agreed. Yeah, go ahead.
So what I'll do is like I divide my life into 4 stages. 2 days back I turned 40, so I can 10 years each. I can divide into different areas, so that will be easier. So since type 2, as I mentioned, 0 to 10 is about fractures, probably. I think most of the parents here probably would have known. And as a child, you would not remember when you were like born until 5-6 years. You do not know how much fracture you had, but I think I had triple digits most of the time. So every time I used to have fractures rather than not having fractures. But what happens like around 6-7 years, I think the repetition of fractures reduced. That's probably to do with the muscle strength and all that came up. The calcium supplement I used to take, probably that taken account. And of course, the lifestyle changes and all. So 0 to 10, I can always talk about it's probably pain, and not, of course, not pain for me. It's probably pain for my parents, my family, relatives, because they had to endure through to make it work. And 10 to 20 is the phase where you kind of ask why it is happening to you, why there's things to do. Your personality develops in a way so that you can arrange it in a way. So that's where your education starts, higher education, an initial level of career. This is the life when I say about 10 to 20, it's like 80s, 90s, in between that time. India has been progressing long, like, so what happens, like initial days, I used to be in a school where my parents used to take me, carry me to the school and come back after that when it is done. So there is nothing like wheelchair accessible place. If it is a multiple story building, my parents used to come, carry me over and go there. And it didn't last like for a month or so. It was like completely till my end of engineering. I didn't have to go. My parents had to go through this particular session. So it was pretty difficult for my surrounding to make it, comfortable for me to pursue my education and all. So that was most of the questions that I have. My 10 to 20 was why this is happening, what else I can do. So then after 20, the next phase where 20 to 30 is where you try to prove yourself that with this condition you can do better. So then you try to do a little bit extra compared to the others so that you outshine or you do something. And you try to find, your voice from the crowd. I think that is where my education, my initial level of career, where I did have to do a lot of effort to make sure it works out. And this way, do a lot of research so that I can actually live an independent life, or do a lot of, thought experiment, like what can happen if this was done, that was done. Then at that time, whatever, first is job security. You want to have a job which is financially viable for you. And from Indian perspective, when we come with any kind of disability, the most of the big factor comes with your financial, because you need to overpay compared to the normal people, right? Like coming from a middle class family, it is not commercially viable most of the time to pursue that kind of lifestyle, that where we always need a car to go somewhere. It's very difficult to use public transport. Wheelchairs are like costly, and you need to have, it's now and again you have to pay a bit more extra, so that financial freedom comes into picture. So then the current stage, or just which I left, like 30 to 40. In this phase, what I had, I got an opportunity to come to abroad, where I came to US, Chicago, in that way to for my job opportunity. At that time, I had a very different view about how you live independently with disability, or any kind of condition that is. And I think first time I generally saw people with wheelchair doing the same career that I am in. Previously, I never got a chance to see anybody like that. And then that opens up a lot of my perception of how I can live differently. So living independent, trying to learn about yourself, trying to do things much like hobbies that I picked up because I had a lot of me time to do all these things. And you try to develop your personality, which generally happens in like your 20s or teens or 20s. And then you can have your relive your teens again. So that's what happened for me, 30 to 40, like which currently happening right now, I guess. But since it is 40, I'll probably go into a different phase. Maybe if you have another interview after 10 years, I probably can say it differently. But I think out of that phase, I think right now I'm in a stage where I'm an independent person. I can see what needs to be done in the near future, or at least I have an idea how to deal with things. And that's pretty much exactly how I see my life. And the question about how you live with OI, with India and abroad, I just give two different scenarios. Personally, I do not think so. There is a personality-wise, that will be different. You have the same personality that you go with, same struggles that you do, same insecurity, same depression, or whatever condition that comes with disability will come, irrespective of whichever part of the globe you are in. And your family, irrespective of wherever they are, they will be always supportive, friends always. It's universal in nature. So there is nothing you can compare. That quality of life, emotional quality of life would be different compared to different. Other part is financial type of life, the governmental part of life, the infrastructure part of life. There is a huge difference that we will see compared to India and abroad, right? And in India, when I talk about like 90s, when I was growing up, to like 2000s, where I was working, that was a drastic difference. In 90s, there was no, how do you say, wheelchair accessible concept there. But when I like started working in, let's say, Bangalore, Kolkata, Bhubaneswar, wherever I worked, the new buildings were always wheelchair accessible. The concept of accessible bathroom was really new for me, but that thing happened there. So, of course, with time, people do change, things change. But for me, from my point of view, I felt the infrastructure and the other support system, which is like can be done by government, like education, transport, healthcare, much better outside India. My outside India is, I haven't gone through everywhere, mostly US and Sweden right now where I am. So I think that was a big difference that I found. So this is what I have. If you have any question, I'll be really happy to answer.
Dr. Madhuri and Paranjyoti ma'am.
Saswat, can I ask you a question?
Absolutely.
What was the major challenge you faced abroad? You're telling outside India it's much better than India, but what was the challenge that you have faced?
Cooking. I never went to kitchen in my life. The first time I went to abroad was I need to cook for myself. It was really terrible experience. That was the biggest challenge.
I know. I understand. Okay. How did you solve it, Saswat?
YouTube.
No, YouTube. That's what all of us do, the same thing. Don't worry.
Hi, Shashwat. I have one question for you.
Sure.
You talked about your experience. I wanted to know how is the perspective of people around you, the difference between India and abroad. Can you elaborate a bit more on that?
I mean, you need to segment it. When you say people around you, it's like people around you, like family, friends who are close to you. Irrespective of which part of the world you are, they will always be similar based on your interaction with them. When you talk about people who do not know you, strangers, right?
Yeah, that's what I meant.
Yeah, so their perception is basically how well they're, how do you say, equipped. Like if you go to a rural village in some part of India, I mean, people will be curious looking at you. You look like very different, short height with a wheelchair and all. It will look different. They will be curious about it. Of course, they will be asking. You can take it as a rude behavior. You can take it as this. I take it as a curious. If I see something odd, then I want to see, right? So there is no harm in that.
It's cultural here, yeah.
Yeah, it's cultural. That is all fine. If you go to a place where people are educated, some are like overeducated also, they get really worried that when they see people with some kind of problem, they do not know how to act, right? And it's basically type of communication, how you communicate. And some people, based on their background, their experience, they behave. So I tried doing this experiment, like how in general different places treat people with wheelchair. Till now, I'd never come up with a one pattern which can answer. I would answer like it varies from people to people, how they are. It's very difficult to generalize.
And the other question is, how about the government's the policies, to help the difference again between India and
Absolutely.
yeah.
I mean, it's pretty evident. India is a very population is very high. The resources are very low. The distribution of resources into population is always going to be difficult. So it doesn't matter it's a government problem or this. If your family has 20 kids, one person, all the kids do not get the same things, right?
Yes.
It doesn't necessarily it's a government problem. It's just a allocation of resource problem that happens. But if you go to a country which has more resources, they would have more time and investment to make a lot of people come into the mainstream, right? So I would say if you go to the resourceful, rich countries, they probably have a better way because they've been matured. Like at least in Sweden, they made a law in 56 or something around that every building which needs to be built has to be accessible, right? And 1950, 60, like say, consider India, Brazil, like South American countries. I don't think so. They had, I think eating food was a major problem. Wheelchair access, I don't think so. That comes into the list. So yeah, government support, of course, if you go to a rich country or rich place, they have much more experience in managing. If you are in a lack of resource place, you compensate with human, like how people can help, right? That's how it is.
Right.
Yeah,
Thank you.
I understand. I understand, Saswat. Of course, resources are the main thing. Accordingly, the improvements. Tell me, what are the major improvements that India has to do for all this, so that maybe somewhere something can happen? Major improvements, you feel?
I think infrastructure probably would be the biggest hurdles, right? Unless we make our school, colleges accessible, it becomes
accessibility
very difficult.
Should be very good. That's correct.
Yeah. That's probably the first thing I would do. Next, also, if you have a lot of people coming out into a different level, then people can see. Since I go to different places with wheelchair, people see me coming there, they try to accommodate. If 10,000 like me coming, it is not somebody to accommodate. It becomes mandatory for them to do it.
Yes, definitely.
That's how it is.
I understand. It's very low in India, definitely. I see even in foreign countries, even the public transports, they come down, the vehicles, they come down and easily accessible for the people.
Yeah.
I have seen it. Thank you very much.
Thank you, Saswat, for your time.
Thank you.
We will now move on to a talk by a parent. Paranjyoti ma'am, can you please introduce her?
Yeah. Once again, yes. See, support groups we all have plays a very important role when it comes to rare diseases, especially in a vast country like ours. Correct, no? To be heard and noticed of proactive involvement of the parents in these groups is it's very vital. Okay. In this regard, I have one parent, Anitha Venkatraman, who is an electronics engineer from Bangalore, and she's working in IT sector, and she has two children. One son who is 9 years old, his name is Ioif. The other daughter is 3 years old, Anvi. Now she's going to share her thoughts with us. Please, let us welcome Anitha Venkatraman. Please come on, Anitha.
Hello, can you hear me?
Yeah.
Yes, we can.
Yeah.
Hello, everyone. A very good evening. My name is Anitha, as been introduced now. I have two kids. My elder son is 9 years old, Ioif, and my daughter is 3 years old, and she was diagnosed with OI type 6 4 months back. We don't have a family history of OI as such. Both me and my husband have been carriers of the same gene, which has caused OI in my daughter. It was only last year that she started showing signs of OI, and in the past 1 year, she has gone through a chest injury, 2 pulled elbows, 4 femur fractures, 1 tibia fracture, in short. And only after the for 3 femur fractures, what she referred to a genetist and told for genetic testing to be done, because till then her pediatricians and doctors were very sure that she's not OI. Only after that they referred her to a doctor for genetic testing. And clinically, when she was diagnosed in the beginning for OI, they suspected her to be OI type 1. But when we went for a genetic testing, when the results came out, it was OI type 6. And it is one of the rare types compared to the type 1 or type 1, the most common type. And a genetist, genetist, our doctor who saw my daughter, said that not many cases of type 6 are found, because people don't usually go for genetic testing. At many times they are clinically diagnosed. That is where the type of the OI is misjudged. So it was like he told the importance of genetic testing to us, and he told us to be sure. He was very he told us genetic testing is really important rather than clinically diagnosing the condition. And the first thing which we learned is that as soon as our daughter was diagnosed, or the word came up, we have an elder son, so I had to make sure that even he is understood about what it is. So we talked to our son, we told what it is and what OI is, and we like educated him and told him how we should handle our little one. Because when two kids are playing together, especially when there's an elder or a younger sibling, children don't know that sometimes even the smallest of things might hurt an OI child. And letting your family and friends and the near ones or helps, and letting them know what it means and educating them is really very important. I learned when you have a little one at home. And creating awareness in today's situation, like how everybody says in India, not many people know. So creating an awareness in a society is also very important when it comes to your neighbors, or when you take your kids to play in the park, or the schools or educational institutions. The most basic thing is when you go to an hospital. When my kid was fractured, even there, or when they were trying to take blood for her blood test, even the nurses didn't know what OI is or what brittle bones mean. So we had to tell them. They were trying to hold her down very tight. That might also cause a break. So even there in healthcare institutions, most of the nurses and healthcare people, they also do not have much knowledge. So educating there is also very much important to create an awareness. And one more thing in this short span which has helped me is that pediatric ortho's suggestion, or you can say his tip for us, is that don't restrict your child too much, is what he says. He told us that the more you restrict her and the more you don't let her do some things, then her bones might weaken. When you try to avoid and restrict her so that she doesn't break, it might break in the other way by weakening her bones. Or it might even mentally affect her due to too much restrictions. So the approach we take is that we just let her do whatever she wants to do, but we are constantly there, and we are there with her, one or the other person, trying to be there for her, trying to make it as safe as possible, so that she just lets herself be. And that is what has probably kept her smile and the glitter in her eyes intact, I can say. But it is different when your child is very young, very small, when they don't understand what is happening. It is on the onus is on the parent. So you have to be sure what is good for your child and where you want to draw the line. But as a child grows, maybe even the child understands, and it is you can give the responsibility to the child to know what he wants to do, because he or she very well understands what he or she is capable of, what they want to do. And so it is on the child. And one more thing I would like to emphasize is that being a new parent in this OI thing, when my daughter newly got diagnosed, I was very confused, muddled up, and I didn't have much idea about what it is. So everything is Google. So I used to Google a lot. That is where I came across Ioif website. I found a number there, and I called up the number on the page, and it led me to Archana. And she was so helpful. I can't thank her enough for that. She has given me pointers to doctors, and I asked her for another type 6 family so I can connect with somebody. And within a few hours, she sent me a number, she gave me directions, and I could connect to a family in Nepal. And from there, I could get pointers and directions, and they joined me to an OI type 6 Facebook group, which is particularly for type 6 patient kids or parents, or OI type 6 group as such. There I got a wealth of information. As a parent who is new to this, who has no information about what is going on, it was really helpful. And there I could get information regarding new clinical trials for type 6, new research, and then they helped me to contact one doctor who is on clinical trials in an international somewhere abroad, a doctor abroad, a German doctor. As a community, this was quite helpful when there are such rare genetic disorders, or where there is not much help as such outside. When you come together in these social platforms as a group, it helps a lot, because you do get a lot of information, lot of experience sharing, where you get a knowledge of what is going on and what new trials or researches are going on, what somebody else is doing who is in your situation, and what across the globe people are going through. As such, it has helped me so much to understand what is happening around me. And then we have this Ioif, Indian Osteogenesis Imperfecta Foundation here. I feel, though we have international groups and all that, our system of healthcare and what goes in our country is quite different. So using this IOIF, I think we can become more close-knit as a community and raise awareness here in India. And we can share our child's experiences with each other, especially parents who have young children, I feel. Because somebody has already gone through what your child is going through. Somebody would have experienced it before. So you can share experiences, become more close-knit, and share knowledge with each other is what I believe in. Because the main thing I feel is, as soon as there is a red flag, you see, get diagnosed and try to get help to manage this condition, start the treatments, to become more aware, create a society which is more aware, and that would help a lot in a long way. 3, what I feel is, these social media platforms or social media groups as a community, when we come together, we can help each other in the long run in a nice way, because when we share experiences, we can help each other in a very good way. This is my takeaway from whatever I have learned in this short span of time. And I hope I have put my points across. And thank you, Archana and Ioif, for giving me this opportunity today. And a very happy Wishbone Day to all the warriors out there.
Thank you, Anitha, for those kind words. And we look forward to more proactive interaction by parents like you, so that we can go further in this cause of OI. Thank you.
Sure. Thank you.
Thank you. We'll now move on to our next program for the day. IOIF has been supporting many children throughout Karnataka and in other states for their medical as well as surgical treatment, as well as certain rehabilitation. So we have a short video presentation for y'all, which is a message from various beneficiaries that we have received. A small video presentation from IOIF.
Hello everyone. IOIF has been supporting patients with OI in several ways. We have made a video in which some of our beneficiaries express how they've been supported by the organization. Hemalata, a 13-year-old girl with her mother from Karnataka. IOIF funded her surgery at IGICH and helped her with a smartphone donation and engaged a volunteer to help her with her virtual learning.
ತುಮಕೂರು ಜಿಲ್ಲೆ ಗುಬ್ಬಿ ತಾಲೂಕು ಇಂಡಿಸ್ಕೆರೆ ವಿ ಕೋಡಿಯಲ್ಲಿ ನನ್ನ ಹೆಸರು ಹೇಮಲತಾ, ನಮ್ಮ ಅಮ್ಮನ ಹೆಸರು ಕಮಲಮ್ಮ. ನನಗೆ ಓದ್ಕೊಳ್ಳೋಕ್ಕೆ ಸ್ಕೂಲ್ಗೆ ಹೋಗಕ್ಕೆ ಆಯ್ತಿರ್ಲಿಲ್ಲ. ಅದಕ್ಕೆ ಫೋನ್ ಕೊಟ್ಟರು IOF ಕಂಪ್ನಿಯವರು. ನನಗೆ ಆಪ್ರೇಷನ್ಗೂ ದುಡ್ಡು ಕೊಟ್ಟರು. ಥ್ಯಾಂಕ್ಸ್. ನನ್ನ ಹೆಸರು ಕಮಲಮ್ಮ. ಇಂಡಿಸ್ಕೆರೆ ವೀಕೋಡೋಡಿಂದ. ಆಮೇಲೆ ನಾನು 3 ಮಕ್ಕಳು ಕೂಲಿ ಮಾಡಿ ಸಾಕ್ತಾ ಇದ್ದೀನಿ. ಇವತ್ತು ನನ್ನ ಮಕ್ಳುಗಳ್ನ ಓದಿಸ್ತಾ ಇದ್ದೀನಿ. ಒಟ್ಟಿನಲ್ಲಿ ಇದು ಅವ್ರಿಗೆ ಮೊಬೈಲ್ ಕೊಟ್ಟಿರೋದಕ್ಕೆ ಹೆಲ್ಪ್ ಮಾಡಿರೋದಕ್ಕೆ ಅವ್ರಿಗೂ ತುಂಬ ಥ್ಯಾಂಕ್ಸು. ಆಮೇಲೆ ನನ್ನ ಮಗು ಕಾಲು ಆಪ್ರೇಷನ್ ಮಾಡ್ಸೋಕ್ಕೆ ದುಡ್ಡಿರಲಿಲ್ಲ, ಅವ್ರಿಗೂ ದುಡ್ಡು ಕೊಟ್ಟಿರೋದಕ್ಕೆ ತುಂಬ ಥ್ಯಾಂಕ್ಸು.
Mahalakshmi, a 9-year-old girl with her mother from Tumkur district, Karnataka. IOIF funded her surgery at IGICH.
ನಮಸ್ಕಾರ. ನಮ್ಮದು ತುಮಕೂರು ಡಿಸ್ಟಿಕ್ಕು ಟಿಪ್ಪೂರು ತಾಲೂಕು ಬೋಚೇಳಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು ಒಂದು ಹಳ್ಳಿ. ಇವಳು ನನ್ನ ಮಗಳು ಮಹಾಲಕ್ಷ್ಮಿ ಅಂತ ಹೇಳ್ಬಿಟ್ಟು 9 ವರ್ಷ ಇವಳಿಗೆ. ಇವಳಿಗೆ ಹುಡ್ತಾಗ್ಲಿಂದಲೂ ಮೂಳೆ ಪ್ರಾಬ್ಲಮ್ ಇದೆ. ಇಂದಿರಾ ಗಾಂಧಿ ಹಾಸ್ಪಿಟ್ಲಲ್ಲಿ ತೋರಿಸ್ತಿದ್ದೀವಿ ಇವಳನ್ನ. ಅಂದರೆ IOIF ಕಂಪ್ನಿಯವರು ನಮಗೆ ತುಂಬಾ ಹೆಲ್ಪ್ ಮಾಡಿದ್ದಾರೆ. ವೀಲ್ ಚೇರ್ ಕೊಟ್ಟವ್ರೆ. ಮತ್ತೆ ಮೂಳೆ ಕಟ್ಟಾಗಿತ್ತು ಇವಳ್ದು. ಆಗ ಆಪ್ರೇಷನ್ಗೆಲ್ಲ ತುಂಬಾ ಹೆಲ್ಪ್ ಮಾಡಿದ್ದಾರೆ. ನಮಗೆ ತುಂಬಾ ಇವಳಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ಸೋಕೆ ಆಗ್ತಿರ್ಲಿಲ್ಲ. ಯಾಕೆಂದರೆ ಮಾಡ್ತಾ ಇರೋದು ಕೆಲಸ, ನಾವು ಕೂಲಿ ಕೆಲಸ ಮಾಡ್ತಿದ್ವಿ. ಅದಕ್ಕೆ ನಮಗೆ ಇವಳಿಗೆ ಟ್ರೀಟ್ಮೆಂಟ್ ಕೊಡ್ಸೋಕೆ ಆಗ್ತಿರ್ಲಿಲ್ಲ. ಆ ಸಂಸ್ಥೆಯವರು ತುಂಬಾ ಹೆಲ್ಪ್ ಮಾಡಿದ್ದಾರೆ. ಧನ್ಯವಾದಗಳು.
Nurullah Huda, a 9-year-old boy with his mother from Bangalore. IOIF funded his surgery at Rainbow Children's Hospital for deformity correction and telescopic nailing of his right femur and tibia.
मैं नूरुल्लाह की मम्मी हूँ. मेरे बेटे का ऑपरेशन के लिए मैं रैम्बो हॉस्पिटल गई. तो रैम्बो हॉस्पिटल में जाने के बाद अमाउंट इतना बोले तो मेरे पास उतना अमाउंट नहीं था मेरे बेटे का ऑपरेशन करने के लिए. तो मुझे बाद IOIF की तरफ से मुझे हेल्प मिला है. मेरे हस्बैंड कार मैकेनिक हैं. तो कमाने वाले वो मेरे हस्बैंड अकेले हैं. तो हफ्ते का ऑपरेशन पैर का हुआ है. तो इसके लिए मैं बहुत थैंक यू हूँ. मेरे बेटे का IOIF की तरफ से मेरे बेटे को मदद मिला है. तो ऑपरेशन होने के बाद फिर दूसरा पैर का ऑपरेशन करने के लिए मुझे कुछ टाइम लगा. और तो कुछ दिन के बाद मुझे वो भी पैर का ऑपरेशन हो गया है. तो अभी मेरा बेटा थोड़ा सा ठीक है, बेहतर है, खड़ा होता है, थोड़ा बहुत चलता है, तो थोड़ा अभी खड़ा हो रहा है थोड़ा.
IOIF has been supporting patients in many other ways too, like wheelchair donation, zoledronic acid injection treatment for the needy patients, virtual learning, and many more ways. We are grateful to all our donors and supporters and look forward to their continued support for the OI community in India. Thank you.
Hello everyone, myself Jasmine. I'm a computer science engineering student doing my first year at UVC College of Engineering. Today I can't find words to explain and express how thankful I am for getting a treatment check. For somebody with OI, it is challenging for them to go to school or anywhere. I felt more challenging when I started going to my degree college, because we know that degree colleges are usually big. It was difficult for me to move around. I was using a normal manual wheelchair, but I could not travel long distances with it. So we requested IOIF team for an electric wheelchair which would be helpful for me. So they immediately accepted our request and worked on it. Today I am here to thank everyone who contributed to it for me to get an electric wheelchair. Me being from a medical family, with a financially weaker background, it was not possible to buy an electric wheelchair, even though I had a need for it. So I'm really thankful and grateful for all the kind-hearted people who helped me. Thanks for all the support. Surely it will be helpful for me to be more independent, to be more mobile and gain confidence. And it will make me to pursue my education in a better way. Thanks for all the support.
Thank you. I thank Dr. Madhuri for having compiled this short video. I now request Paranjyoti ma'am to kindly say a few words about our wheelchair donation as well as the future program.
Namaste, everybody. I have a very important announcement. That's main thing is, we are doing a lot of volunteers engaged in teaching these kids. And many of the kids are learning virtually, of course, because of this COVID situation. And many of them are progressing very well. So not only surgery cost and all we want to look for, we also want to encourage them to go further in their studies. So we are very shortly going to announce, we are planning the scholarships for all these needy students who will study very well. I hope all of you will take this benefit. Thank you.
Thank you. We have come to the end of the program, and now is the time to have a small vote of thanks. Dr. Madhuri will be leading us with the vote of thanks.
I cannot start my video, Abhishek. It has been disabled by the host.
1 minute now. Yes, ma'am, you can start now.
Okay, yeah. Hello, everyone. On behalf of OIIF, I thank Mr. Venkatesh from Youth for Seva, as well as his volunteers, Mr. Rashil and Mr. Rohit, for the logistic support they have provided today, and also for the constant encouragement from their group. I thank Vivika for the melodious start to the event. A big thanks to Dr.Vrisha Madhuri for her very enlightening talk on stem cell therapy for OI patients. And a huge thanks for Saswat for joining all the way from Sweden and sharing his experiences with us. And our heartfelt gratitude to Ms. Anitha for telling us how important it is to have social support groups to deal with children who have OI, especially for the parents. And last but not the least, I would like to thank the Osteogenesis Imperfecta Federation of Europe and Care for Brittle Bones for their encouragement. Thank you to all the participants who patiently watched this program and also actively interacted to make it more interesting. Thank you.
Thank you one and all for joining us today during this virtual celebration. We look forward to have in-person celebration soon once all this COVID situation improves. Thank you all for joining us. Thank you. Rashil, you can end the meeting.